Looking at primary graft dysfunction on the intensive care, is the patient hemodynamically stable? Is the pressor support reducing? The one I like is the lactate falling to less than 2 millimoles per litre within 36 hours. I think that's a benchmark that the graft is recovering and settling. And it's also a sign of multi-system functioning that is reassuring. Urine production, is it there? Are you still having to support the patient on hemodiafiltration? I guess that worries me a little less, because if the graft's working okay at 48, 72 hours, you will tend to see urine production start back up. The need for continuing ventilation, again, that's a secondary issue. I then like to look at the dynamics of the INR and the AST. Is it continuing to go up, or is it plateauing and or starting to come down? I also like looking at phosphate levels. A falling phosphate and the need for energetic replacement is often a sign of early hepatocyte recovery and the start of a regeneration. And as Dr. Reddy said, I think it's following progress day by day. But for me, in terms of assessing patients, the key times are between 36 and 48 hours and between 5 and 7 days. If you haven't retransplanted a patient by certainly 10 days, you're getting into very difficult territory where survival, I think, is the same for retransplantation and for medical management within the intensive care. So by 48 hours, I'd expect to see a normal lactate, less than 2. I'd want to have seen the AST-ALT peak, and I'd like to see it falling. And certainly by the second post-operative day, I'd like to see the AST at 2000 or less. Anything higher than that does suggest that you're going to have a degree of graft dysfunction. An AST of greater than 10,000, I would say, is an indication of severe graft injury, and the threshold is there for considering retransplantation. I've spoken about all of these other aspects on that slide. The 50-50 rule from this paper by the French group in Paris of predicting early mortality after hepatectomy applies to liver transplantation as well, and is a useful way of managing these patients. And we had an early experience of using ICG. There have been papers, particularly from the Far East, on its value in identifying patients with poor graft function. But I have to say, in our hands, we couldn't find it useful, and particularly for the individual decisions on patients requiring retransplantation. But that may just be us. The other condition that can sometimes cause problems is non-thrombotic infarction of the liver. This is a rare condition occurring after cadaveric transplantation in probably 1 in 4 or 500 liver transplants. And it usually starts between day 5 and 10 post what seems to be a fairly uncomplicated cadaveric transplant. It's a stable patient with good graft function, and the AST starts to double from usually somewhere between day 5 and 7. A biopsy will show no rejection. Vessels are patent on ultrasound and CT. And as you follow the patients, AST doubles, the INR becomes prolonged, they become jaundiced. You should be aware of this condition. It always creeps up on you by surprise if you haven't seen it before. And usually by day 12 to 14, the patient's condition is becoming more serious, and they do require retransplantation. So this is quite distinct from early graft dysfunction. It's rare. People often haven't seen it, or the team have forgotten about it, but just keep it aware. It's there in the literature. You will see it very, very occasionally following cadaveric transplantation. I'm not aware that it's been reported after living donor liver transplantation. So clearly, with cadaveric transplantation, for the surgeon, the assessment of graft quality is really important. Age greater than 60 years was one of the early factors considered in determining marginal grafts. I think over time that's become less important, but it remains a risk factor. Steatosis is probably the key one. It's certainly the most visible risk factor, and much has been written about that. I would say livers with steatosis of less than 30% should be used, and it can be used confidently without much risk of graft dysfunction if there are no other risk factors. Once you have steatosis above 40%, this becomes a real risk. This is a graft that will have some degree of graft dysfunction, and it's how you make it work satisfactorily and safely that is the challenge for the surgeon. There are other risk factors. I think particularly diabetes has been poorly controlled, and the presence of peripheral vascular disease in the donor. These are covert risk factors that are often quite difficult for the transplanting surgeon to assess. Abnormal liver function. Well, again, quite a lot has been written about this. But actually, if you've had a patient who's had a hypoxic or ischemic injury and it's recovering and the AST is falling, these are livers I like. They've had ischemic preconditioning, and you'll often find that they work well. So an AST that's falling, that's come down to 200, 250, that's fine to use. An AST that's rising and has reached 1,000, this is a dangerous graft. And in the absence of machine perfusion, you should certainly avoid using these grafts. Prolonged hospital stay of 5 days. Well, if the donor's been fed enterally, I think this is much less of a risk. I'm not going to talk about the other factors, other than to say the use of inotropes, unless it's adrenaline, I don't really pay much attention to unless they're very high. Just being aware of the effects of aging. This is a perfectly good liver to use. This is from a donor over 70 years of age. The white fibrosis on the capsule of the liver is merely cosmetic. The liver, albeit small, albeit slightly darker because of the presence of lipofuscin, will work perfectly well. This is a moderately fatty liver. With care, this will work satisfactorily. This is a severely fatty liver. This is a much more dangerous liver to use. And we can talk about ways of trying to manipulate these livers with machine perfusion to make them usable. So as I say, much has been written about fatty livers in the literature. This is an early publication from Tom Starzl, and certainly in the early 90s, livers that had severe fat were seldom used. But now I think this is the challenge for us, is how do we make the most of that? But much of graft dysfunction is defined not by one single criteria, but multiple ones. And here in this publication, they looked at the contribution of individual risk factors such as donor BMI as a covert marker of fat, cold ischemic time, serum sodium in the donor, and so on. And it's an accumulation of risk factors rather than one that usually determines the severity of graft dysfunction and or non-function. And in this more recent paper looking at early allograft dysfunction, you can see that after multivariate analysis, the risk factors for early graft dysfunction included recipient MELD, pre-transplant ventilator status, donor age, DCD, cold ischemic time, The actual liver mass, which is an interesting one, moderate steatosis, operative time, and volume of red cells transfused. Donor liver mass is an interesting one. Um, Obviously, you'd expect the liver to weigh about 1.5 kilos. Once the liver weighs more than 2.5 kilos, even in a large donor, you can expect there to be at least 30% fat. And for a liver weighing up to 2.93 kilos, you can expect it to be approaching 50% fat. So I think liver mass is interesting. When you're doing cadaveric transplantation, you should always ask the retrieving surgeon for an accurate donor weight at the time of retrieval, so you get an idea of what to expect. One important point about early graft dysfunction is that it's associated with higher incidence of graft loss and mortality early post-transplant. But this also translates into late survival. And you can see here that these curves of graft survival and patient survival for the top line is no early graft dysfunction. The lower line is those patients who experience early graft dysfunction. They're not only different from early on, but they continue to separate out. So early graft dysfunction is associated with both early and late graft loss. And this is important, and again, hasn't been clearly tackled in the literature as to how we might change that trajectory. I'm briefly going to mention some recipient factors now associated with graft dysfunction. Dr. Reddy has also already talked about them in the context of living donor liver transplantation, where they're really very clear. So severity of liver disease and recipient MELD. Severity of portal hypertension. Often young patients are the ones who have really severe portal hypertension and shunting. And I think this is a particular challenge for surgeons at the time of surgery, particularly in association with massive splenomegaly. Previous surgery and infection, and occasionally, high levels of donor-specific antibodies may provide a second hit to the liver, which can be difficult to pick up, but should be borne in mind if you've got unexplained early graft dysfunction. And then there are the technical issues. We've mentioned portal venous inflow. Hepatic artery inflow is usually obvious. Venous outflow, particularly in piggybacking techniques, can be important, but usually manifests in the weeks after rather than in the first few days post-transplant, unless it's severe. And as one of the questioners mentioned, the presence of venous shunting and portal venous insufficiency is being increasingly recognized.